Hi, everyone. This is Rachel, the project coordinator for our Early Psychosis Learning Collaborative. I just wanted to review a few housekeeping items with you all before we begin. The participant microphones will be muted at entry, and you'll be able to unmute them during the discussion portion. During the presentation, if you have any technical difficulties or questions about the topic, please use the chat feature. This webinar is being recorded and you'll be available for viewing at a later time on the MHTTC website. And to reach us after the webinar, you can email newengland@mhttcnetwork.org. Our MHTTC team is composed of C4 Innovations, Harvard University, and the Center for Educational Improvement. Our MHTTC's mission is to use evidence-based means to disseminate evidence-based practices across New England. Our area of focus is geared towards recovery through recovery-oriented practices and support services within the context of recovery-oriented systems of care. And to ensure the responsiveness of our work, we will actively develop and maintain a network composed of different stakeholders from each of the 6 states to guide our activities. And with that, it is my pleasure to hand it over to Dr. Raquel Meshlam-Gately for introductions.
Thanks so much, Rachel, and good afternoon, everyone, and thanks for joining us today. My name is Raquel Meshlam-Gately. I am a psychologist from Beth Israel Deaconess Medical Center in Boston, involved with the New England Mental Health Technology Transfer Center. I'd like to welcome all of you to today's webinar, which is part of a series of initiatives by the New England Mental Health Technology Transfer Center on mental health care during the COVID-19 pandemic. We will be regularly updating these initiatives on our website, and we'd welcome any suggestions for other resources we can provide for wellness, recovery, and connection during these challenging times, not just for the people you serve, but for yourselves as well. As I'm sure you're all well aware, the pandemic is causing a marked increase in mental health problems, as well as a significant disruption in healthcare, along with a rapid increase in the utilization of telehealth. This has posed challenges for safety planning and risk management for individuals with psychosis. I've invited my colleagues, Dr. Shirley Yen and Dr. Lauren Utter, to address this important topic, both through their presentation and any questions you might have in the end. Feel free to type those questions, comments, and ideas into the chat box as you think of them, and Drs. Yen and Utter will respond to them right after they finish their presentation. So it's my pleasure to introduce Drs. Yen and Utter. Dr. Yen is a clinical psychologist and associate professor in the Department of Psychiatry at Beth Israel Deaconess Medical Center and Harvard Medical School. Her clinical and research interests are in the area of suicide risk assessment and developing and testing interventions that reduce suicidal behavior. She's also the training director of the Clinical Psychology Training Program at the Massachusetts Mental Health Center. And Dr. Utter is a clinical psychologist with a faculty appointment at the Harvard Medical School who specializes in working with young adults with psychotic disorders. She provides services at the Prevention and Recovery in Early Psychosis program and Young Adult Services in Boston, and she has prior experience with On Track New York and the Yale School of Medicine Specialized Treatment Early in Psychosis program. She's provided clinical supervision and mentorship to numerous trainees and is passionate about recovery-oriented treatment, social justice, and improving systems of care. So, without further ado, welcome Drs. Yen and Utter for joining us today to speak about safety planning and risk management in psychosis spectrum disorders during the COVID-19 pandemic.
Thank you so much for that introduction. Let me see if I can share my slides. Okay, are you able to see my slides? Yes. Okay. Oh, good afternoon, everyone. Thank you so much for joining us. I'm delighted to co-present with my colleague, Dr. Lauren Utter. Today we'll be talking about safety planning and risk management in psychosis spectrum disorders, with special consideration of the challenges of having to do so during a pandemic. Now, neither one of us have any financial interest to disclose. And our main objectives today are to present the steps of developing a safety plan with attention to the limitations that we're facing right now due to COVID. Also, we'll talk about risk management for when the safety plan is not enough. And this includes the use of involuntary commitment and all the issues that need to be considered before taking this step. And we'll also talk about crisis planning and potential harm reduction strategies to decrease the risk of violence for when clients do have encounters with law enforcement. Now, we know from a substantial body of research that having psychosis symptoms increases risk for suicidal behaviors. And that's true for the full spectrum of suicidal behaviors, including suicide ideation, plans, suicide attempts, and deaths from suicide. Now, it's estimated that among those diagnosed with schizophrenia, about 20 to 40% have made a suicide attempt, and with approximately half of those having made repeat multiple attempts. And it's also been estimated that about 5 to 13% of those diagnosed with schizophrenia die by suicide. The risk of suicide and suicidal behavior is generally higher earlier in the course of psychosis illness. Compared to the general population, the suicide death rate for those with early psychosis is 11 times higher in the year after initial contact with treatment, and 7 times higher 5 years later, and 4 times higher 10 years later. And the median time to suicide is 5.4 years. So this risk does appear to diminish over time, though it's still elevated compared to the general population. Now, those with psychosis spectrum disorder share many of the same risk factors for suicidal behavior that apply to the general population. Some examples of static risk factors, which help us identify who is at risk, include past history of suicide attempts, family history of suicidal behaviors, and specific psychiatric diagnoses such as major depressive disorder, substance use disorder, borderline personality disorder, PTSD, and certainly there are other risk factors as well. Some examples of dynamic risk factors, which are subject to change and help us identify when a person is at risk, include depressed mood, hopelessness, substance use, sleep disturbance, social isolation, a recent loss of a job or relationship, recent legal problems. It's really important to pay attention to the changes in these indicators or changes in functioning. And then there are also some risk factors that are specific to those with psychosis spectrum disorders. As I had mentioned earlier, risk for suicide attempts and death in this population occurs earlier in the course of illness. And this is in contrast to the general population, where you have the highest rates of attempts in teens and young adults, but the highest rates of suicide deaths are in older adults. And the risk for suicide also tends to be higher among those with good premorbid functioning or insight, or those with more awareness of their psychosis illness. Other times when risk is particularly high is right after an inpatient psychiatric admission, or when one is emerging from a post-psychotic episode. Now, that being said, there is a risk for suicidal behaviors in episode as well, though this is usually accompanied by positive symptoms such as hallucinations or delusions. Now, those with psychosis are also more likely to engage in non-suicidal violent behaviors relative to the general population. So it's estimated that less than 10% of serious violence towards others is due to psychosis. So the vast majority of violent acts in our society is not perpetrated by those with psychosis, but regardless, it is associated with an increased odds of violence. One meta-analysis that looked at over 200 studies estimated that psychosis was associated with a 49 to 68% increased odds of violence. And violence is more likely to be directed towards familiar individuals, and when the individual is feeling threatened, or that their personal space is being invaded, or that their rights have been taken away. As an example of this, in one study, involuntary treatment was the only factor associated with violence in the period following initial first episodes of psychosis treatment. And other studies have found that after treatment for first episode psychosis, rates of violence in patients with psychosis drops gradually to rates close to those in the general population. Now, some of the most consistently cited risk factors for violence include past history of violence, low insight into illness, substance abuse, and medication non-adherence. Now, the current pandemic has brought on multiple challenges on many fronts, personal and professional, I'm sure. By now, almost 9 months into this, you've all probably figured out ways of working with your clients, either remotely or in a socially distant manner. Nonetheless, it's worth reviewing some of the additional steps that might be considered to manage or monitor risk remotely if you aren't already doing some of these things to begin with. One is having informed consent in place for telehealth that states your expectations and the limitations to telehealth. Also, whenever possible, choose, if possible, to do video telehealth because video provides so much more additional information. It does allow you to detect when someone is agitated or when they're having affective shifts or flattened affect. It's also helpful to know or get in the habit of asking where the client is at the start of your phone, video session. So ask where are you? Is there a callback number if the video connection is lost? It's also important, if at all possible, to agree for them to allow you to be in touch with collateral contacts, whether that's family members, significant others, friends, to the extent that's allowable. And this is particularly important because risk management requires an all-hands-on-deck approach. We know that oftentimes suicidal or violent ideation is not communicated to treatment providers, but it is communicated to family members or other close contacts. So having these collateral contacts in place and a collaborative relationship with them is really instrumental. And if you haven't done so already, consider developing or reevaluating safety plan if you have one in place. So the safety plan intervention that I'll be talking about is based on the work of Barbara Stanley and Greg Brown. There are other safety plans out there, but this is a widely used one and has a lot of empirical support. SPI is a standalone adjunctive intervention that can be implemented by either an individual's primary therapist by integrating this into their ongoing therapy, or by someone who's not their therapist, such as a covering or supervising clinician, clinician on call, or someone in the emergency department. It's a one-session evidence-based intervention that takes about 25 to 45 minutes. It does not replace any longer-term intervention and incorporates evidence-based risk reduction strategies such as brief problem solving, use of coping skills, enhancing social support, and identifying emergency contacts, as well as means restriction. Now, SPI was originally developed for those at risk for suicide, and that includes those with suicide ideation but don't meet the needs for hospitalization, or those who've had a recent suicidal crisis but are currently denying that they have any suicidal ideation, or anyone who has risk factors for suicidal behavior. However, SPI can also be modified for other at-risk behaviors quite easily. For example, relapse prevention, or other behaviors that involve strong urges or detectable urges or triggers. Now, it's important to mention that has not been empirically tested for other behaviors, but I am aware that other clinicians modify the safety plan for that purpose, for other purposes. And so here are all the steps of the safety plan intervention, and it's important to note that the creation of the safety plan is really just one part of a larger clinical encounter. Now, the first step is risk assessment and hearing the individual's story. That's really important for the individual to feel heard and for this to be a collaborative process. It's all too easy for a client just to deny any suicide ideation, especially if they think that it's going to result in them getting hospitalized. And you may even want to discuss with them that doing a safety plan or going through this process actually might help keep them out of the hospital. And while you're listening to their story, it's important to pay attention to information that you might want to use later in their safety plan. So here's some suicide risk assessment basics. Now, these are certainly some of the most important questions to ask, but it's not comprehensive. As I mentioned, therapeutic alliance is key, and it's really important to be collaborative, compassionate, and authentic, and not treat a suicide risk assessment as sort of a checklist. You want to certainly cover assess suicidal ideation. How often do you find yourself thinking about suicide? How long have you been feeling this way? Intent. How strong is your urge to die? Do you intend to act on your suicidal thoughts? And if it's not yet known, their past history of suicide attempts. Do you have a specific plan? What is your plan? Have you been mentally rehearsing or practicing this plan? And means, do you have what you need to carry out your plan? Do you have access to firearms? What about substances or large quantities of medications? And also, not to forget the protective factors. What are some of the things that have kept you alive? What do you value? And what's important to you? Now, most of these are focused on the present, the here and now. That's not to say that the past is not important. You know, for example, understanding the past history of attempts and what they have done is quite important. But we have to recognize that we don't have necessarily too much of their time and attention. So it's better to generally focus on what we consider the dynamic risk factors rather than the static ones. After assessing for risk and hearing the story, it's important to get their buy-in to want to create a safety plan. So it's often helpful to provide a rationale that thoughts and urges come and go. And the purpose of the safety plan is to have a detailed list of strategies to help them get to the times when the thoughts and feelings are most intense and to prevent them from escalating. And it's hard to think clearly when one is having strong feelings and urges. So the next step is to create a safety plan, and you can easily access a template like this online or make one yourself. And there are also safety planning apps for smartphones. So as I mentioned, this is the one based on the work of Barbara Stanley and Greg Brown. There's 7 steps, the first 5 being hierarchical as they escalate in terms of intensity of the intervention. But it is okay to just jump up to any step depending on what they need in a moment of crisis. And the last 2 steps, they're not hierarchical, but they're important things to kind of keep in the background or to revisit periodically, and that is to how to keep the environment safe and identifying reasons for living. So the first step is to identify warning signs and triggers that precede suicidal crisis or whatever type of crisis you're trying to manage for that particular client. It's important for this to be individualized and as specific as possible. So you want to present the rationale for identifying warning signs, that it's easier to implement the safety plan. It's more likely for all this work to be effective if you can use it earlier in the process. So I've listed some examples here of what people commonly mention, but the key is to be as specific as possible. So if they say thoughts or triggers, you want to know specifically what thoughts. If they mention strong feelings, well, what feelings tend to trigger you? Is it feelings of anxiety, feelings of anger? You want to get specificity. And again, you can easily adopt this for relapse prevention or other behaviors that involve triggers. Oops. Step 2 is the internal coping strategies that one can do on their own. And this is important because people are often alone when they're thinking about suicide or having coping strategies that they can use by themselves, enhances self-efficacy, it instills a sense of personal agency. And it's particularly important for people who suicide ideation who may have a long-standing habit of reaching out to others. So some examples of what might go in this step is going for a walk, listening to music, taking a shower, exercising, engaging in hobbies, video games, TV. The idea is to distract your mind. And once they've identified some strategies, it's important to evaluate how likely are they to use the strategy and how likely is it to be effective. Are any of these strategies potentially problematic? So for example, if someone's suicide plan is to jump in front of the car, then taking a walk might not be a good coping strategy. Or music can be great, but it can go both ways. So I often encourage clients to create a safe playlist. It's also important to evaluate any obstacles to using these strategies, and to identify which are the most feasible ones. So step 3 is about identifying social contacts that can provide distraction and possibly connection. So the goal is to get people outside of themselves and connect with others. It's not necessary to talk about their current stress. So with regard to people, identify individuals who clients may have a non-complicated relationship with. It can even be a cordial relationship. The goal is not to self-disclose the crisis, but to identify people who can provide distraction. This could be a younger sibling or a niece and nephew to play games with, or someone that they can play video games with remotely. If they live in a group home, who can they co-distract with? Now, with regard to places, you might want to ask, where can you go when you have the opportunity to be around people in a safe environment? Now, this is the strategy or the step that is most compromised by social distancing. In normal times, some examples might be grabbing a book, getting coffee at a coffee shop, or going to the gym for a workout, or going to the basketball court and see if I can get into a pickup game. This is really hard now. We might have to be creative and think about, are there digital gatherings, taking a walk, getting out in nature in a socially safe way, playing an online game. But one of the silver linings of the pandemic is that online communities have definitely flourished, and there are more online possibilities for connection. And that's actually a little bit more socially, more acceptable for people who have social anxiety. Step 4 is about contacting family and friends who can provide support during a crisis. Now, theoretically, these are different than those people listed in step 3. In this step, the client would solicit support, not just distraction from these individuals. So it might be important to ask, how likely would you be to contact these individuals? Can the safety plan that we're developing be shared with them? Sometimes it becomes challenging to identify people for this step. You don't want to leave a blanket if you can at all avoid it. If you're struggling to identify family members or friends, see if there's a 12-step program, sponsors from AA or NA, peer support or peer navigators that they can turn to. If they live in a group home, are there staff members that they can turn to? And if you're really drawing blank, just say, well, let's go back to this later. We can fill it out at a later point. Professional support is also important to identify. You want to have the phone numbers and of their mental health providers or the agency where they seek help readily available. This is also a good opportunity to educate clients about crisis lines. The people who work on these hotlines have lots of experience talking with people who have thoughts of suicide or other mental health crises, and they're really good at talking people through the moment. They won't necessarily have a knee-jerk reaction of sending individuals directly to the emergency department. However, if they are concerned enough, they will certainly call an emergency intervention while keeping the individual on the line. And for you who really don't like to make phone calls, there is also a crisis text line that's available. And now there are Spanish-speaking and hard of hearing options as well. Depending on where you live, there might be emergency psychiatric evaluation services aside from the emergency department. So, for example, in Massachusetts, in the Boston area, we have an emergency service program called the BEST team that are staffed with behavioral health professionals. There are many reasons to try to avoid the emergency department right now, if at all possible. Step 6, as I mentioned, this is not the next sequential step, but it's something that's an important reminder as the client is navigating each of these steps. Means restriction is a very important and effective tool in suicide prevention and relapse prevention. It's important to know what are the things that the client needs to keep distance from. And it's important to get collateral support to help you in this step. We know that firearms are the most common cause of suicide deaths, and that the states with the least restrictive gun laws also have higher suicide rates. And sadly, in youth, these firearms usually belong to parents. So it's important to ask, are there firearms at home? And are there large volumes of medications around? If you're doing this via telehealth, this may be a good opportunity to do a virtual safety tour of their home and have the patient secure identified items with you. And finally, it's important to think about and write out reasons for living. What's kept you going so far? It may be a particular family member or a loved one or pet, or it could be spiritual reasons that suicide is against your values, or maybe suicide might prevent you from doing things that you still want to do. You could also adapt this for reasons for sobriety. So after completing the safety plan, it's worth reviewing it with the client and thinking through the logistics of where they plan to keep this plan. I often recommend taking a photo of it using their phones and asking whether they feel comfortable sharing this with anyone. You may even want to consider having a specific meeting with family members or group home staff just to go over the safety plan in a collaborative way. It's also worth reminding them that they don't have to do the steps sequentially, but they can jump to the strategies that are most helpful in that moment. And the safety plan is a living document. If you have the opportunity, it's good to go back and revisit to see if it needs updating. Now, at this point, I'm going to turn it over to my colleague, Dr. Lauren Utter, to talk about crisis management, when the safety plan is not enough. So at this point, I will hand it over to you.
Thank you. And Dr. Yen, we did have one of the participants ask if we might be able to enlarge the screen anymore, and I wasn't sure if that was possible. Would you mind clicking just to the next slide just for me to see how it might look? Okay. Looks okay on my end, so for any of the participants, please send a message in the chat if for any reason this is good. All right, people are saying it's much better, so great. All right, so good afternoon, everyone. I'm going to be speaking some about the process of involuntary commitment and also risk management, with particular consideration for when some of our clients, particularly those that are people of color, are having contact with law enforcement in the process of crisis intervention or involuntary commitment. So outpatient mental health providers, many of you who are here today, are often faced with challenges of, whether or not we need to pursue an involuntary psychiatric evaluation. You'll see throughout today's presentation, I'll be making references to the term section. That's a term used in Massachusetts to pursue an involuntary psychiatric evaluation in a hospital. But this can also be referred to as an application for admission, an involuntary emergency examination and treatment. So you want to make sure that you're familiarizing yourself with the terms as well as the civil commitment laws and standards in the state where the clients you are treating reside. The nature of a section or an application for involuntary commitment really is that it's giving authorization for an individual to be taken against their will, possibly through restraint, to be transported to a hospital for further assessment. In Massachusetts, although it's quite similar in other states, there's usually some clear criteria that a person needs to meet in order to be considered in need of this type of involuntary evaluation. Here in Massachusetts, it poses substantial risk of physical harm to self. Often we see that with suicidality. substantial risk of physical harm to others. And then also, when a person's judgment is so affected that they're not able to protect oneself to live safely in the community, and there's no other reasonable alternative that exists. And I'll talk in a little more detail about each of those. Okay. So again, as Dr. Yen has noted, doing a very thorough assessment, but collateral has always been quite important in risk evaluations. However, I have noticed that treating individuals remotely, collateral information is more important than ever. And so I'm often looking to family members, group home staff, individuals, such as even sometimes reaching out to visiting nurses or anyone else who may be having contact with that individual face to face, to really be gathering more information about if the person might be eating or drinking regularly. Are they using substances? Are they noticing an increase in self-dialoguing or disorganization? What does their home look like? Are they caring for themselves? Again, you really want to pay attention to what are some of the dynamic versus static risk factors when making a decision about if a person needs further evaluation. Aspects such as ideation, intent, plan, means is very important as well. And the area where I find that sometimes criteria can be a bit complicated about whether or not a person meets criteria. It's very clear when a person has an imminent risk to hurt themselves or others, but sometimes when an individual's judgment is so impaired by the nature of their mental illness, commonly with psychosis, some of the symptoms or behaviors I've found is when a person's experiencing catatonia, sometimes pretty pronounced paranoid ideation where they've stopped eating or drinking and are at risk of medical issues, sometimes not being able to recognize the seriousness of a medical condition and not engaging in treatment. Again, people have the right to, decline medical treatment, but sometimes due to the nature of the psychiatric symptoms, the person may not be recognizing the severity and it could be life-threatening. Sometimes I've seen disorganization. A person, based on their symptoms, are walking into moving traffic, sometimes engaging in behavior that's leading them to maybe lead them to potentially face legal consequences or be injured unintentionally. And I'll give an example of that. One young man whom I've treated was really struggling with chronic auditory hallucinations of what he was hearing as what he believed to be his girlfriend having sexual intercourse with neighbors. And so he began throughout his neighborhood going and attempting to record what he believed these acts to be occurring throughout his neighborhood in the evenings. And while it might not have been an imminent risk to himself or others at that time, based on what I was aware of going on in that neighborhood at that time and that type of behavior, he was at significant risk of, based on that poor judgment and the nature of his symptoms, that he could be seriously injured if he were to have a confrontation while doing that based on the delusions that he was having. There is really a time and place for us to use emergency services such as emergency rooms or inpatient admissions, but it's important that we always keep at the forefront that these experiences of being involuntarily committed or going for an involuntary evaluation in an emergency room not only can be highly adverse, but can be traumatic. It can be traumatic as the initial event. It can also be re-traumatizing for many people who have, especially individuals who have experiences with physical as well as sexual abuse histories, to ever experience either chemical or physical restraint in emergency settings. Just the loss of freedom of being involuntarily committed, and then just the quite stigmatizing nature of receiving sometimes emergency crisis services, but also in neighborhoods and areas where people live, ambulance, police responding to the home. This can really have an effect on the individual and the community. I have found that sometimes these services can, when we involuntarily have someone go for an evaluation, rapport can be greatly affected between the client, sometimes their family, as well as with the provider. And this is particularly important with the early intervention population, as they're really being introduced to the mental health system and what care might look like. And sometimes having a very negative first experience in a crisis at a hospital can really be formative, and not to mention, a lot of the focus of being on an inpatient unit is to quickly stabilize and be released. And sometimes that means medications being administered in doses that are higher than what would be recommended for an FEP population or first episode psychosis population. And doesn't always fit with the principles of care that we try to have in that treatment. Also of note, many of you are likely aware that the assessment of when we determine when a person needs an involuntary evaluation is quite subjective, and sometimes there can even be differences of opinion within the same treatment team. Once a person is determined in need of that evaluation, even upon getting to the emergency room, who's making that decision on if the person will be, committed to an inpatient unit or released, really, again, is quite subjective. And so it's important that, if you are a provider who, it's different in each state, depending on who is able to actually engage in involuntary commitment. Some states it's only a physician, others it's a county administrator. Here in Massachusetts, it's actually quite wide-ranging in terms of who can complete a section. But it's important to be aware of some of your own background and what might be influencing your risk tolerance. I've seen many times there be potentially a recent suicide or something happen in a clinic, and then see that there immediately after is an increase in the number of sections for anyone who's presenting with suicidality. And so it's important that you communicate with your colleagues and really talk about when you're to do something like an involuntary evaluation, that you have feedback from others. Here's some questions or considerations that you might want to think through. It's always a very dynamic process in terms of making this type of decision. I have found that knowing whether a person lives with others can often be very helpful. So if a person is a young person that lives with family, if they're in a group home setting, is the group home setting 24/7 staffed, 16 hours staffed? Who else might be able to sort of monitor a situation if you're concerned goes a long way. Likelihood of a person or supports contacting 911. There have been many killings recently of Black individuals in contact with police. And so in the communities in which I work, in which it's predominantly clients and families of color, they are very concerned about calling 911. And so when I'm talking to a family about possibly a long weekend and whether or not they're going to call 911, many parents have been very clear with me that they will not. And that's something that I can understand where they're coming from. And I also have to keep my risk evaluator hat on what that might mean if I'm on the fence about if an individual needs to have an involuntary evaluation. We always want to have, do the least harm and ideally work with a person to see if they might be evaluated voluntarily. Is it safe for a person to transport them, or would it be safer for an ambulance? Sometimes we can partner with a prescriber to see if possibly there's just some medication changes or even a PRN medication that can be called in for the person to prevent needing to go to an emergency department. In Massachusetts, we have what was called a Rogers guardianship, which is a way that there's a mandate or an approved treatment plan for an antipsychotic medication. If a person has a Rogers guardianship, sometimes going to the emergency room is something to quickly allow them to get back onto their medications and be released very quickly versus a person who does not. In other states, such as New York, there's assisted outpatient treatment. So if a person's not following their outpatient plan through the court, that might also weigh into whether or not you feel that they might need to be evaluated. Court involvement. So if you're working with an individual who already has a number of open charges based on some of what occurred during psychiatric decompensations, and now they're again having symptoms that potentially could lead to further charges, is it in their better interest to be able to get to a place of safety? Such as that young man I gave the example of, if he had already had open charges for trespassing or something like that, and now he's recording people in their windows. You know, these are all dynamic factors to consider. We always want to be aware of the resources in our community. Is there a less intensive level of care? So sometimes there's crisis stabilization units that are considered voluntary admissions or peer-run respites. Are there places that an individual can go for a period of time that is not involuntary or considered a hospital stay? We want to think about, even though, you know, we need to send a person ideally based on our clinical opinion, based on how they're presenting, but it's difficult to not sort of be aware of the hospital in which we're having the person go, and the likelihood, right? In a big, busy public hospital, what is the likelihood that this person will actually be seen as in need of a stay, and what is our hope of an inpatient admission for this individual? We've had clients that have gone to the emergency room late in the evening and it's the middle of the night and they're re-released, and now they're sort of walking around in the streets with no one available from our treatment team. And so we want to think about the time of day, what's the likelihood, the impact on your relationship, and then what is the degree of risk that we're looking at if you do not do this action. Okay, so when we think of racism, I think what comes to most people's mind are often the interpersonal nature of racism, and it might be in the form of slurs or a violent act, but racism actually exists throughout systems, and we see that in organizations through just the way things are, the dominant culture, the policies, the procedures, the practices, we know that systemic racism is occurring anytime we really see disparities based on racial, ethnic background of the clients or the individuals served. And so this is often where I hear people say, you know, I'm not racist though. And people can be anti-racist and have very good intentions, but that does not mean that systemic racism still might not be occurring, even though the individuals who work within those systems are actually practicing in an anti-racist manner. And we see these kind of disparities really through the criminal justice system as well as healthcare. As well as there's a lot of studies looking at implicit racial bias and the ways in which we automatically and again unintentionally react to certain groups. And there's a lot of stereotypes that look at you know, particularly young Black men as being dangerous. And if you were to, you know, ask people if they believe that, generally people will self-report, no, I think everyone's equal, or I don't have those kind of racial attitudes. But it's, again, these are often unconscious and are built up over time based on the dominant culture. And part of why I have this slide is because this has implications for our decision making. Even though we might wish that this was not the case, it's important that we all are mindful and have awareness of these things, as it has implications even for decisions about involuntary commitment. So things that you can really be aware of is your social location as a provider, aspects of your identity that afford privilege, what's your racial ethnic background, your gender, your socioeconomic status, the neighborhood you live, your immigration status, do you have documentation? These are all things that often factor in to a person's perception on whether or not they feel safe interacting with police. Do we view them as people who are there to protect us or to harm us? And if we do have contact with the police, how does that usually go? And these are things to think about. And I've really learned a lot over these last few years and working with families of color who really have, you know, pointed out to me that as I'm doing safety planning and trying to focus on their ability to call 911 in case of emergency, have really brought a lot to light around my areas of privilege, and the way that I would view police versus other people of color. So some statistics: Black men have a 2.5 greater likelihood of being killed by police than white men, and also, are very overrepresented in prisons. Not only is it mostly Black men who have a greater likelihood of being killed by police, but it's actually younger Black men, and who can sometimes make up the large portion of some of the early intervention for psychosis programs. And so I share this because there's still things that we can do as individual providers while systemic level change is still needing to happen. So these are different for each state, but just very quickly, I wanted to bring up that there's a number of different, often initiatives that are going on, both at the federal as well as national level. So there's a number of police-based jail diversion programs, as well as the idea really is to try to help people get good treatment as opposed to them being involved in the criminal justice system. And so at a national level, there have been a lot more crisis intervention training, CIT teams that are actually training police officers more in mental health, de-escalation, because this is not only for to help our clients, particularly those of color, have less violence and brutality towards them during involuntary commitments, but it's also if police are better able to de-escalate situations, they're also safer themselves, as they also can be quite injured during some of these interactions. There can be co-response programs, such as clinicians can actually go and ride along with police to be able to respond to an involuntary commitment evaluation. And then, as Dr. Yen mentioned, emergency service programs. These are called different things, so you should search it for your state, but most states do have a 24/7 mobile crisis response that you really want to be aware of, if they can potentially work alongside the police and not in silos. So some thoughts about if you are to engage in a section or need to call 911. Some thoughts are that the provider really should be reaching out to the police district in the area where your client resides. And this is information you should already have prior to the emergency situation. You want to be able to see if there can be a coordinated effort with specifically a CIT trained officer or a mental health clinician who is designated in that police district. You can also go ahead and contact the ESP or the emergency service program or 24/7 mobile crisis team to enter alerts proactively, so that if they are brought in either by the police or the family or client, they have more background on what is happening. You can sometimes ask for enhanced wellness checks as opposed to engaging in a section. It's important to work with the client and family prior to an emergency, so that they understand what they might say to police or on the phone to a dispatcher if they need to call 911. These are all examples of things that you can do if it is not an imminent emergency, right? If someone is holding a weapon, or if there is a situation, you don't not necessarily have time to engage in all of these proactive steps, but sometimes we do have that a few hours or even a day or so. In terms of actually calling 911, it's important to be aware that when you're engaging in a section or an involuntary evaluation for bringing a person to a hospital, usually police are required to respond in most states due to the involuntary nature of the section. And so many times families will say, well, can just the ambulance come? And oftentimes that's not possible. So it goes all the more reason why it's important that it's a coordinated effort. You want to be really aware of, as much as possible, to prepare the client if possible, but also the family and other people. You know, for example, in group home settings, it's important that you're communicating to ensure that other people also in the area are kept safe and hopefully removed from that experience, as well as preparing the environment. So I've worked with families who are aware that unfortunately the young person in their home is going to need to be involuntarily evaluated. And so they've intentionally moved the person to another room in the house that's a safer area versus being in the kitchen where the person is more likely to possibly grab a kitchen knife or grab some other type of weapon that's going to put them even more at risk of being harmed by the police, as well as them harming the police. It's important to think about what can make this be an experience that is the least traumatic, and also that there's some degree of accountability. And so I've sometimes been on the phone when police are there with EMS responding, that I have the family announce that I'm on the phone. Sometimes there's a degree of accountability that goes on with, sometimes in some states there's different laws related to recording of police, but sometimes there have been injuries and families and clients wish to pursue sort of lawsuits or complaints. And so it's important that documentation is being gathered about who was responding, the time, what type of injuries occurred. And then you also want to be sure to be aware of what emergency department a person's been taken. So often we can indicate where we want a person to go, and the person might also have preferences. That doesn't mean that the ambulance is going to take them to that emergency department. So you want to make sure you're aware of that. Okay. So there's a lot of considerations for remote work. Just very quickly, you know, knowledge of individuals' location is extremely important, as well as who else is in the home. Sometimes there's children in the home, there's other people living in large adult group residence. Working remotely, you really should have demographic information, date of birth, basic information on the client, in case you need to complete an involuntary commitment application. Access to technology, Doximity is really a great resource, as well as being aware of what kind of access do clients, families, staff have to you and your team while working remotely. And so, you know, we've been doing a lot more with Google Voice, having auto text replies on different work cell phone numbers, voicemails, emails, any way that we can help to make this a little bit more smooth during a pandemic. Okay, so just very quickly, I'm going to just go over one vignette. This was a 24-year-old Black man with a diagnosis of schizoaffective disorder who a couple of years ago had actually stopped antipsychotic medication, which was not uncommon for him, and he had a suicide attempt by hanging. This attempt had followed an inpatient admission, so this was a very critical high-risk period where he had been continuing to struggle with command auditory hallucinations, not sleeping, was pacing, and he had made this attempt. We had been able to engage in safety planning with him, but more recently, at the time of our assessment, the family, our collateral, were able to tell us that the individual was not sleeping, he was pacing again for the last few nights, and when we were able to evaluate the client, he disclosed himself that he had been spending a lot of those evenings trying to talk and persuade the voices to really leave him alone, as they were beginning to become increasingly more mocking of him. He had endorsed passive suicidal ideation, but denying active SI or plan or intent. Denied means at that time, we were able to update his safety plan and really bring family into the discussion about how they might be able to provide a bit more structure, more frequent check-ins. He was amenable to this. We were also able to make some medication adjustments to help him really help with some of his sleep and address the worsening auditory hallucinations. And we also were able to enter an alert with the emergency service program in the area, so that if he were to make contact or family were to make contact in an evening or on a weekend, that the ESP would have awareness of the seriousness of his past suicide attempt and some of the risk factors to help inform whether an involuntary commitment was necessary. So I think for the sake of time, we probably won't look at vignette 2, but if you get a chance, I encourage you to take a look at it, as it really speaks to how an example of being able to coordinate with a number of entities throughout the system, in an example where we were able to safely engage in a section without violence, although we had predicted that violence could have occurred based on history of this individual and response to police. With that being said, I believe we have about 5 minutes left. You see we have some acknowledgements and resources, and we will turn it over to about 5 minutes of questions.
Great. I want to thank you both, Dr. Yen and Dr. Utter, for this wonderfully informative and helpful presentation. And we've already had a few comments and good questions, and I'm going to try to read out a couple of them, but for everyone else who's watching now, if you have any other questions or comments that you want to share, please just type them in the chat box and we'll try to address them as we can. So one of the questions we had is, how do you change or adapt your approach if the client has children in their care with limited options of family or supports who can care for the child?
Well, I think that's an extremely challenging situation, and the welfare of the child really has to be considered paramount. So I think that, and you know, without knowing the age of the child, I think, you know, I think it's important to develop the safety plan. I'll talk about the safety plan part, and then Dr. Utter can talk about the crisis management part. But I think, you know, it's important to, while you're developing the safety plan, to also keep in mind the safety of the child and not to put too much emotional stress on the child as part of their safety plan. But I think this is probably an even more serious consideration if you're considering involuntary commitment. So Dr. Utter, do you want to talk a little bit about that?
Sure, and to be, you know, I primarily work with young adults, and so it's the opposite direction in which I'm working from, where it's really they're the young person in the home. But I think just the only thing I would add is that I like to be informed, and so if there is an individual who has children and I'm getting increasingly concerned about the need for a potential involuntary commitment, I really would be doing my homework as much as possible to know what resources are available, to be asking the police department what happens in these situations, is our clinician part of the response, what might be available, so that I can be having some of these conversations with the individual I'm concerned about and helping inform the safety plan actually based on what resources and the very likely response that these systems of care are going to have upon let's say a section occurring.
Thank you. Another question that we received was, can you speak to the enhanced wellness check?
Sure. So my understanding of enhanced wellness check really is when, you know, police often can do wellness checks. Those are things that people sometimes ask, you know, they're concerned about an elderly family member, they haven't been answering their phone. But an enhanced wellness check, some police departments are partnering with clinicians, emergency response programs or mobile crisis teams to actually have a clinician go out with the police when they do the enhanced wellness check. So that's really all that is. But you have to be very intentional in explaining to the police as well as the clinicians of what it is that you're looking for by asking for the enhanced wellness check. It often, the last thing I'll say about that is that Sometimes for these emergency response mobile crisis teams, the individual has to voluntarily be willing to meet or speak to those providers, but with an enhanced or non-enhanced, just a wellness check, those are things that you can do without the person their consent due to due to police being involved.
Thank you. And there's several other really helpful comments I see here about different apps that might be useful, psychiatric events directive tools, and I think we're going to try to compile them and list them with the notes for this presentation after, so that everybody can take advantage of these wonderful resources that others are posting. But again, I wanted to thank both of you for presenting today. And I know, Rachel, you have a few closing comments to wrap things up.
Thank you all for attending today's webinar. You'll be receiving an evaluation form right afterwards.
Okay, great. Well, thanks everyone again. And, as was posted, the recording will also be up on the website tomorrow. Thank you.
Thank you.